Heart failure is among the most devastating diseases in cardiology. Lifetime risk of heart failure in the U.S. rose to 24% in 2025, meaning roughly 1 in 4 individuals will develop heart failure in their lifetime. Age-adjusted mortality rates have risen consistently since 2012. Roughly 6.7 million Americans over 20 years of age have heart failure. This number is expected to reach 8.7 million in 2030. These statistics persist in spite of a growing number of treatments and procedures to prevent or alleviate the condition and its effects. In many cases, patients are simply not aware of the options available to them.
Despite its tremendous economic, clinical, and public health burden at the population level, heart failure unfortunately has a limited footprint in terms of public policy and public awareness compared with other chronic conditions such as cancer. We must reframe as a community how heart failure is perceived and improve the public health awareness of the prognosis and available treatment options that we have today to manage and treat heart failure. Furthermore, heart failure, which previously was reserved to siloed management with advanced cardiovascular specialists such as advanced heart failure specialists, today should be democratized to the care under the care of multiple clinician types, including primary care doctors, general cardiologists, nephrologists, endocrinologists, and this team-based approach may best manage heart failure today.
In September 2025, the Heart Failure Society of America and the American Society of Preventive Cardiology issued a joint statement, encouraging clinicians to treat heart failure not as an end stage from which patients must recover, but as a preventable condition. The statement highlighted strategies to manage risk factors earlier in disease development, including glucose management, genetic risk screening, lifestyle interventions, weight loss, and blood pressure control.
Yeah, I mean, I think the biggest thing related to heart failure that is challenging and that we don't that we have to figure out how to overcome, I guess, is just getting medications to patients. Like patients with a diagnosis of heart failure, only a very small percentage of them are getting on guideline directed medical therapy. So if you think in the last few years, we've had so many amazing trials. Like literally every meeting I go to, I'm not a heart failure physician. I'm a preventive cardiologist, and I'm like, every late breaker is another new heart failure medication or more evidence of one of the newer medications that these medications can change lives. And to me, the biggest obstacle is getting them to patients. Like we are just not doing a good job. When we have such amazing treatment that can reduce hospitalization, um, and reduce mortality. I mean, the hard endpoints that these studies have looked at, and we're not getting our patients on those medications. That's really concerning. And why is it? I mean, you know, to some degree, is it the cost of these newer novel therapies that are prohibiting patients from accessing them, meaning their insurance is denying them and they can't get them? Or is it as a medical community that we are ineffectively writing these medical therapies for people? And I don't know. I think it's a bit of both. I mean, I think that certainly there is obstacles to getting medications that are as they are more expensive. And it's certainly this sort of prior authorization stuff has created intentional obstacles, I think, to getting our therapies to our patients. But I also think that people have these ideas that we're going to add medications in stepwise, which is all well and good if we get them on into the patient. I think the problem is you see a patient with acute heart failure hospitalized. If you don't start it in the hospital, everybody down the line who's taking care of these patients will assume that there's a reason that other medications haven't been started. And we know that if it isn't written, first of all, in the hospital, is much less likely to be continued thereafter. But also, I think that um, our trepidation um, of thinking that we can't start all the medications together needs to really have we need a mindset change. Like we need to start thinking more about getting the medication started when we're seeing the patient, that there isn't necessarily, I mean, you can go stepwise in terms of increasing the dose, but getting a little bit of everything into the person and having a plan on discharge about when these are going to be increased, when we're going to assess you and your response to it, and when they're going to be increased. And I think part of it is even our healthcare system that's contributing to this because people could have the best of intention of getting a patient in within a week, but it's not always as easy unless you have the resources or and the team members, meaning our advanced practice providers need to be an intrinsic part of that. And if you don't have that in some communities, they may not always have that. Like we talk about it in an academic setting, and it may be in some places easier there than in the real world setting to get patients in a timely fashion with this intention to treat to the recommended doses. But we can't keep continuing like this. This is what heart failure is so prevalent and also takes, a huge financial burden to the entire healthcare system. $30 billion um, is essentially what I think the estimated amount of money that we spend annually on heart failure admissions. If we keep going, it's just going to get worse. And so we have to have a more well designed um, response that we should, get like, how are we gonna get all the patients on the right medications? And you see people like, Dr. Fonro at, UCLA. I mean, love him, and I'm not a heart failure physician, as I already said, but I love because I feel like he's a preventive cardiologist now. Like, he is, the same as we wanna get patients on guideline-directed medical therapy, so do all the heart failure physicians, and there's not enough of them, out there to be treating, so it has to be everyone's job.
Another of the primary issues raised by many heart failure clinicians is the challenge of actually getting treatments to patients. The driving force behind this difficulty is not entirely clear, although several factors contribute to the disruption. From enforced limitations through insurance coverage and prior authorization to communication breakdowns over stepwise therapy prescriptions in and out of the hospital, patients are often not receiving the medications and treatments that could help them regain their lives.
The biggest thing change has been that this conversation of that heart failure potentially is preventable and that heart failure prevention spans the entire spectrum, um, of heart failure, meaning even in tertiary heart failure, there's a role for prevention. And so this conversation, I think, in our community and in the heart failure community, so I mean, in the prevention community as well as the heart failure community, has been a change that, of course, should have started sooner, but nonetheless is now here. And I do think it's interesting. I think, this is where words really do matter because you change the mindset even of our community that we can be proactive and preventive. And I think that that's really changed because I hear it. I actually sit in the midst of a whole bunch of heart failure colleagues and, somebody jokingly said, "Well, we're glad prevention's sort of in the center of us because that's really the truth." And I said, "Oh, I'm glad too. I hope we all think like that." And I actually have heard younger colleagues say that they do, within the prevention community, saying that their interest now is heart failure prevention. So hopefully, this changes how we practice and think. And I think it's been so interesting because, of course, our statement came out just before the other statement or commission that came out from Lancet at the same just I think a few days after ours was released, and I think it just means that the community is changing. Like, we're not going to be reactive only. We are good at the reactive sick patient, being reactive to a very sick patient, treating them when they're acutely ill. But how can we change that into more of a preventive mindset?
1RAs like semaglutide in this indication. So far in 2026, even more promising candidates are entering the field, including non-steroidal MRAs. As we continue the year, patients with heart failure will likely have an even broader horizon of treatment pathways available to them.
Well, I tell you, yeah, we had so many wonderful things that came out in 2025, um, with therapies that are already being deployed, coming back to this idea of, prevention and getting at it earlier. So STEP HFpEF looked at semaglutide in HFpEF. Summit looked at tirzepatide in HFpEF. We have SGLT inhibitors that are now moving upstream the class. Recommendation is now class 1. You have the non-steroidal MRAs that are gaining indications. And so I think for me in 2026, more please really is to kind of identify the outcomes and to solidify, validate, confirm what we already were seeing in 2025. I want more of that in 2026. So it's just an exciting time. It would be nice to see this area of direct to patient remote monitoring. And I don't mean medical grade devices, but how do we leverage what they already are wearing or what they're already stepping on? Because there's scales that do electrical impedance, and can we, utilize and leverage those things that patients already have available to them?
With patient and clinician awareness of these treatment options as the foremost issue of heart failure care, experts in the field are calling for unity between specialties and across condition centers. Recent research has pulled from endocrinology and nephrology to highlight the heart's interplay with other organ systems, illustrating potential treatment pathways that cardiology alone cannot access. Heart failure has become a critical condition in the lives of millions, and so clinicians believe that more teamwork is needed to combat it.
Yeah, we can't do it alone. There's no way that we can do this alone. And, ironically and maybe paradoxically, saying that there's prevention, which we need to be doing, means that there's even a larger group of patients that we need to be reaching out to. So, the nice part is that societies have already developed some infographics that help with patient education. HFSA, of course, I'm CardioSmart editor, and we do a lot of patient infographics. Let that do the talking and have those passively educate the patients, have them in your rooms. That will help. But it's multidisciplinary. That's what this approach with CKM really tells us is we need to partner with endocrinology, nephrology, heart failure, general cardiology, internal medicine. We're all coming at this really with the patient in the middle. You can't do it alone. And I think that's the key here is to make sure we begin to develop multidisciplinary care process models and get education to the patient. Let's not be the gate block for patients to understand what they're up against. They want to be healthy, and we need to get the information to them.